Good afternoon, everyone. I'm David Glazer, and with my colleague, Steve Beck.
Hello.
We're here to talk about healthcare pricing. And then actually, I'm going to go through most of the pricing stuff. Steve is going to talk a bit about provider-based billing and both some quick discussions of a proposed rule that came out last month and provider-based billing. Before we dive into quick announcements, first off, if you ever have sound issues when listening to the webinar, you can always dial in by phone, or if it's just more convenient for you to listen by phone than listening through the computer. If you look in the chat box, you can see the 800 number. You can dial in. That option always exists. All of our webinars are now going to appear on SlideShare after we do them. And so this webinar and the other ones can be found. The link you can search on SlideShare for Fredrikson and it'll pop up, but we'll also be sending you a link. You should feel free to forward that link to whoever you want. Our webinars are free, so you can have anyone who wants listen to this. And some of our past webinars have already been posted. We're going to have a special webinar next week. On August 2nd, a new rule came out, a final rule, amongst other things, changes the definition of an inpatient. And we're going to focus on that of the rule next Thursday, so that's August 22nd, special time and special day, 11 a.m. Central, noon Eastern, and that will be 9 a.m. Pacific. We will be doing a webinar focusing, so Katie Burkhardt and we're going to focus on the definition of inpatient and kind of what it means today and how that's going to change under the new rule that takes effect October 1st. The September webinar, regular time on September 11th, is going to be HIPAA training. And those of you who heard our HIPAA seminar last month are going to say, why are we doing HIPAA again? The goal on this webinar is going to be to plunk whoever you want to train in front of the screen, and they can use that for some mandatory training. And since you can do that through SlideShare, we're thinking that this will be a useful opportunity. All right, with all that aside, let's dive in. So you want to make sure you do your pricing correctly, because when you screw pricing up, sometimes the wrath of God strikes down on you. So this is a picture Chase Buddy and I took in Foster, Wisconsin last year, just east of Eau Claire. And apparently the weather was not happy with gas prices at the time. And pricing involves a bunch of psychological things. Gary Larson captured this very nicely with his Don's Discount Shark Cages cartoon. Sometimes pricing can affect everything from the legalities to the psychology. Healthcare pricing is complicated for a bunch of reasons, but it's helpful to take a step back and think about the law relating to pricing. Out in the world, there are two ways prices get set. The normal way is people agree on terms. Whether you're buying a house or buying a carton of milk in the store, there's a price, you agree on it, it's clear. Healthcare is one of the few, it's very hard to think of other examples. It's one of the few situations where things are often done on an implied contract. People don't talk about price. They purchase, sometimes without any understanding of what the thing is going to cost, and then work it out later. And if you had to ask for other industries in which you can think of implied contracts existing, it's hard to come up with them. So in an implied contract, a court has the ability to impose the reasonable result. And they can say, you didn't agree on price, here's what we think the proper price would be. But the only real way to resolve the dispute if the parties don't agree is to go to court and establish the price. So insurers can challenge whether your pricing is reasonable, but they don't have a right generally to unilaterally determine the fee of a healthcare organization unless your contract permits it. I'm in an interesting dispute right now. It's a coding dispute where an insurance company is saying, hey, we think that all of the, that you can't use a modifier 25, which is an E&M service separate and apart from an encounter. We are going to treat all of your claims, basically, we're gonna lower the rate on all of your E&M services because we think you're doing ancillaries with them. We've just unilaterally determined to do that. And I'd say you can't unilaterally decide to do that unless the contract allows it. So when you think about pricing, and you think about pricing in an implied, the other place where implied contract can come up is a restaurant special. So let's say you walked into a restaurant and ordered the special and you don't know the price. You're stuck paying with whatever the price is. You can't walk in a fancy steak joint, order a hamburger, leave $1 on the table and say, hey, look, I could have gotten $1 hamburger at McDonald's. You owe me this hamburger for $1. That's not how pricing works. And in the healthcare world, an insurance company can't say, we're going to pay you this because that's what we think it's worth. Things are more complicated about that, more complicated than that. A lesson we've learned is if you get into a pricing dispute and someone is saying you're charging above a certain percentile of price, be careful to look at the data. Had a situation, this was many, many years ago, where an insurance company was alleging a radiology group was overcharging. It turns out they were comparing the radiology group's global fee to a professional or only fee charged in other organizations. They didn't know what those little numbers after the code meant. So be skeptical of data. So a few editorial comments about pricing. I don't think pricing is one of the health industry's best moments. If I were to draw or think of another industry that's like healthcare, it's often airlines, where pricing irritates a lot of people. I blame much of the problem on percentage-based billing, where someone says, we will pay you, 60% of your bill charges. I think a lot of the problems in the world come from that. If I could stomp one thing out, that would be it. And keep in mind that the contracts that increasingly people don't read and negotiate can really shape how this stuff comes out. So most of this session is now just going to be questions and answers that are sort of common questions we've dealt with. So the first one is, can I have different prices for different patients? And the answer is yes. In fact, I think everyone on this call that's a provider of services has multiple charges for identical services. And what I say by that is if you've got 3 insurance companies and you take different reimbursement from each of them, even though you may say you're charging the same rate to every patient, I think that that's somewhat questionable. If you'll take as payment in full $90 from one organization and $95 from someone else, I think it's hard for you to argue that your charge is $100. That's not crystal clear, but I'm much more comfortable saying that your charge is the amount that you expect to take as payment in full. Now, people often say things like, you can't discriminate. And that sounds cute, but discrimination is banned only when it's on an illegal basis, like race or gender or sex or sexual orientation. You can discriminate for legitimate reasons. And one reason you can charge people different things, and that is not illegal discrimination unless you're doing it for an illegal reason. So having inconsistent pricing isn't illegal, but it can create all kinds of collateral difficulties, and we'll talk about some of those in a moment. Now, one important caveat I have to toss out, an area I'm not expert in, involves Robinson-Patman, which is an antitrust prohibition, and it prohibits pricing discrimination on goods. And so they handle goods and services differently. You can charge different rates for different services. You can't charge under Robinson-Patman, with certain exceptions, different rates for goods. So if you were selling crutches, different set of rules apply than to billing for surgeries or physician services. If you provide a discount to a cash-paying walk-in, you're creating an interesting problem because an auto insurer or a worker comp insurer or someone else who doesn't have a contract with you can say, hey, why am I being asked to pay a higher rate than the cash-paying person who just walked in? And coming up with a reason for that can be quite challenging. And so I think you have to be really careful whenever you come up with a discount to the uninsured. And we'll talk about some concrete examples of that in a moment. Often people will say things like, oh, we're not going to, if you pay cash when you come in, we will give you a discount because we don't have to generate a bill. Well, a lot of contracts, like the Blue Cross Blue Shield contracts in many states, will say you can't charge a fee for generating a bill. And if that's in your contract and you're offering a no billing discount to certain patients, you're suggesting that your fee in some shape, way, or form includes a charge for generating a bill. So you have to be aware of what's in your contracts and weird inadvertent ways in which you may violate them when you start offering prompt pay discounts would be another example. Some insurance companies affirmatively prohibit them. So can your group have different rates for different physicians? I think the short answer to that is yes, you can. And the question is what it will mean. First challenge that comes up, Medicare, as we'll talk about in a second, pays you your usual and customary charge. And it isn't clear whether a usual and customary charge is determined on a code-by-code basis or a practitioner-by-practitioner basis. If I'm charging $50 for the service and Steve is charging $100, how do we handle that for a usual and customary? Do we have separate usual and customary charges? The law, I'm not aware of any case that's dealt with that in any shape, way, or form. So I think generally you can charge different rates for different practitioners. It can create a great deal of confusion because people are going to wonder, why is Steve charging more than I? It's interesting, in other contexts, that happens all the time. In the healthcare world, that seems to annoy people more, but I don't know why it's a reason to think that it's illegal or anything like that. If you do bill as a group, I think that for Medicare purposes, it's best to assume your usual and customary is established on a code-by-code basis, but I don't have a good legal basis to point to for that conclusion. So, obviously, you have to give Medicare your lowest price, right? Wrong. That's one of the big myths that's out there. If you look at what Medicare says, Medicare will pay you the lowest of one of three things: the actual charge you submit to Medicare, your fee schedule amount, or your usual and customary charge. And the way Medicare defines your usual and customary charge is your median charge. That's, for those of you who are mathophobes, that's your 50th percentile, or the charge where half of the patients are paying more or half are paying less. So it's not your average charge, that's the mean, and it's not the mode, which is the most common. So if you put this in a concrete example, if you charged one person $5, three people $10, one person $11, and one person $50, the 50th percentile charge on that one is $10 because the same number of people paid more and paid less. And I constructed that example poorly because that one, in that case, also happens to be the mode or most frequent charge. What about Medicaid? Clearly you have to give Medicaid your lowest price, right? Well, this is a tough one. I think we've got, I don't know if we have all 50 states represented on this call, but we're close. So we can't go through the answer to this one because Medicaid is governed by state law. And there's a tremendous variety. In Minnesota, usual and customary charge is defined as the charge you charge most often, which is the mode. Immediately to our south, there's a state that follows Medicare. If you go around the country, there's a great range there, and so you have to know what Medicaid says to figure out what you can do. Can you make a patient pay more than their insurance reimburses? And the answer to this question is, and it depends largely on whether or not you've got a contract with the insurance company. If you have a contract with the insurance company, the odds are overwhelming that the answer is going to be no, but you need to review the contract. Most contracts say that you can't charge more than your co-pay or co-insurance to a covered person. If you don't have a contract with the insurance company, then it's kind of Katie bar the door, since neither of our Katies are here, Steve bar the door. It's whatever goes. If the patient is a Medicare or Medicaid patient, if they're Medicare, if you participate in the Medicare program, then you have to accept whatever Medicare pays you. And participation, which is required for hospitals and optional for physicians, basically means you agree to, you've signed a deal, you're in with Medicare, and you're going to get assignment. Medicare pays you rather than paying the patient. If you don't participate, then Medicare still has a limit to how much you can charge, which is called Medicare's limiting charge, which is 15% over the amount Medicare would allow. Now, if you opt out, you can kind of do whatever you want. You're not then working with Medicare. Remember, opting out is done on a physician-by-physician basis, and when you opt out, you're out for 2 years. But if you opt out, you could charge whatever you want. And Medicaid is going to vary, unfortunately, state by state, making answering that difficult. Can you charge a patient for extras like a phone call? Once again, each payer has a different rule, and this is a thematic problem we've got with answering these questions, is that the answer for every payer in the country can vary, and it makes having different charges operationally really difficult. Now, Medicare prohibits you from charging a patient for any covered service, and this is where your head's going to explode. Medicare considers phone calls to be a covered service. It won't pay for them. They're considered covered but not separately reimbursable. So in Medicare's mind, you can't charge a patient for a phone call. As an aside, if I were going to change one thing in the healthcare system, I might make phone calls covered because I think it would make life happier for all involved, but that's just a Glazer editorial comment there. Most insurers have language prohibiting you from charging for covered services, but they don't necessarily say that a phone call is a covered service. And absent a contract, anything goes. So here's one of the big questions we get. Can I adjust my fees to out-of-network patients to treat them as if they were in the network? This is an extraordinarily controversial issue. The law is, there is going to be a bunch of litigation about this. Insurers have a reasonable position of wanting the network to mean something, to say, hey, when we negotiate a discount, we want it to have meaning. If you don't have a contract with the insurer, things get particularly interesting. Remember, there is a contract between the patient and the insurer, not necessarily between you and the insurer, and the terms of that contract can control. And so ultimately, in my mind, the analysis depends in how the insurance company has structured their charges. If the insurance company has a fee schedule that they pay, then I think you can offer a discount. I don't see a lot of trouble there. The reality is, though, a lot of insurers pay off of either a percentage of your charges or some percentage of a fee schedule. And that's where things are more complicated, because if you are saying to the patient, we're holding you harmless, we're only going to take insurance payment as payment in full, you've created a situation where your $100 charge with a $20 copay and $80 from the insurance company, if you're going to take the $80 as payment in full, if the insurance company's deal is we'll pay 80% of the billed charges, the insurer can say, hey, look, the billed charge is really 80 because that's what you expect as payment in full. We only owe 64. And there are cases that have come out that way. There are some notable ones. I'm thinking of one right now off the top of my head involving a chiropractor in Arizona. I think there was a chiropractor in Wisconsin and a few cases like that that have been reported and gone up. But there are cases that have come out the other way. There was a big case involving HealthNet as the insurer and a New Jersey ambulatory surgery center. And the surgery center said, we'll take insurance payment as payment in full and waive coinsurance. And I would have said, I'm worried about the ASC's arguments here. The court came out and said, no, we think it's okay to waive a coinsurance. Now, part of this might be New Jersey specific, because what the court said was, wow, there's a state law that specifically forbids dentists from waiving coinsurance. There's no law like that prohibits physicians from waiving coinsurance, and had the legislature wanted to, it could have. And so we're going to say that they didn't intend to have physicians limited in this way, and so we think the ASC can do it. This is going to be a topic of big litigation. I'm somewhat nervous about it.
Yeah, I think that it's important for people to think hard about any proposed waiver of coinsurance. And this is an issue that's worth talking about with your lawyers because it is, as David said, fraught.
If you're wrong on this, the penalty can be high. So do you have to provide patients with information about pricing? A few states have toyed with laws that would require you to give, and some have laws, that require you to give a good faith estimate to patients. If it's not required, I still think there's something to be said for doing it. What people often fail to understand is that in all kinds of medical contexts, it's difficult to see. You see this in when the New York Times website is up, you can read stories about how no one can tell you what a hip surgery will cost, and they don't fully understand that there are a variety of factors that may come into play. That's obviously different from an office visit and the like. But an informed patient, if you disclose information to a patient, it's a lot harder for them to challenge you. Are there limits on how much you can raise your prices? Federally, no. A handful of states have toyed with that. I don't know of any off the top of my head that currently have things that limit price increases. But something that you may throw in the back of your mind, under an antitrust analysis, one mechanism the courts use to determine whether someone has monopoly power is your ability to make a 5% price increase stick. And they'll say that if you can do that, that suggests you might have monopoly power. That's not really a legally important point, except just something that if you're a large group and you're thinking about price increases, it's something you may want to be aware of. And we'll talk real quickly about antitrust and sharing of price information as part of negotiations, of merging and the like. Those of you who have heard me talk know that I think that we're schizophrenic when it comes to healthcare. We can't decide if we want competition or if we want consolidation, and we sort of want both. Antitrust laws are pro-competition, and so they want more competitors who don't share information, which is completely contrary to sort of the ACO model of things, and you can see there's this tension going on right now between them. So how do you reconcile a certificate of need law with a desire for, which is going to say we want to have few providers of a service with a desire for competition? And the short answer is you can't. They're inconsistent, and we haven't figured that out. So antitrust is biased heavily in favor of buyers. So you might think it's so unfair. Insurers can get together and sort of decide what they're going to pay us. Why can't we decide to get together and negotiate jointly with them? And the reason is a couple of things. First, insurance companies have a special antitrust exemption. But second, antitrust favors buyers over sellers. Many antitrust violations occur only if you have market power. And market power falls into kind of two areas: the product market, which is what is it that you're selling, and the geographic market, where are you selling it? And so there's a big antitrust case that said the market for cardiac surgery, this was a case out of Omaha, Nebraska, and it said, we think Lincoln, Nebraska and Omaha, which are 56 miles apart, are one market because a patient might drive 56 miles to get cardiac surgery. And the geographic market is generally going to be where could people reasonably go for alternative care. And so an hour drive for healthcare seems like that might be a principle that the courts have adopted. But some things can be violations of the antitrust law and send you to jail even if you don't have market power. And two of those are price fixing and boycott. And so if Steve and I are two physicians in different practices and we agree on we're not going to sign a contract with United Healthcare, or we agree we are going to only sign a contract if they pay us, $65 an RVU, that agreement is a felony even if we don't have market share. Now, if Steve and I are part of the same corporation, whole nother ballgame, because there's a principle in antitrust law that a corporation can't conspire with itself. So even if Steve and I are in different locations or different cities, different clinics in the same city, if we're part of one corporation, we can talk and agree on a price. But if we're not, we can't, and to do so can be a felony. So if you try the psst, quit taking insurance, pass it on, what a great New Yorker cartoon, that actually is a slightly different ballgame. You could decide to opt out of insurance. I think you'd have a better defense there than saying, I won't sign the Blue Cross Blue Shield contract. That's a non-starter. I'm going to blow through one slide and come to one of the weird concepts in antitrust law that you see in airline ads all the time. You can have what's called conscious parallelism, which is Steve lowers his price to $100, and so I go to $100 to match him. If we don't agree, it's legal. The question is, and what makes these interesting all the time, is whether there is a tacit, implicit agreement. If there's an implicit agreement, it's still illegal. The government doesn't have to show that Steve and I actually signed some sort of contract to agree. If they show that we reached a wink, wink, nod, nod thing, that's still illegal. And so, anytime you're negotiating with an insurer, you want to be careful what you're doing with other people. Now, does that mean you can't know what someone else charges? No, it doesn't. And if you think about this analytically, Target knows what Kmart charges. That's okay. You can know other people's prices. The act that's illegal is agreeing. What people will often do is if they want to find out what other people's charges are, they'll often choose to launder the data. And the reason is to avoid the risk of reaching some sort of agreement. And so that's why when you see a trade group blind pricing data, the reason they're blinding it isn't because you're legally required to blind it. It's that blinding it lowers the risk someone argues that you've agreed. So if you're in a physician group and you want to get more negotiating clout, what can you do? Can you say no to a contract? Yes, that's always an option that's available to you. Can you unionize? Well, you might be able to unionize, but you have to understand unionizing isn't an interaction with the insurance company. Unionization is something you do with an employer, and so unionizing isn't really an option to negotiate with the healthcare insurers of the world. Can you and another group agree not to sign a contract? No. Can you get into some sort of merger? Well, yes, with the caveat of, you can't reach the point where you're a monopoly. I will say, I've had a couple of situations where the Justice Department has looked at mergers, and the Justice Department has concluded that because there are low barriers to entry for physicians, even situations where maybe 30 of 31 physicians in a town were in one group, it wasn't a monopoly. So just something to keep in the back of your mind. All right, back to regular pricing stuff. Can I give a prompt pay discount? Well, the short answer is you can, but it's not clear that it's legal. So remember, a lot of insurance contracts prohibit a billing fee, so you have to say, why are you giving it? Often people will say, well, it's the time value of money. The problem with this from a legal standpoint is if you're giving a 5% discount for paying on the day of the service, that's the same as charging 5% of interest for paying the next day. And so someone can argue it's usurious interest. And when I was a young pup lawyer back in the 90s, there were some lawyers who were making that argument. Now, my dentist gives me a prompt pay discount, and I gladly take it. So people do it. There haven't been a lot of cases on it, but you have to be aware that someone could potentially challenge it as having usurious interest. If anyone squeaked, I'd certainly give them the discount. And in theory, an insurance company might squeak. So things to keep in mind. Can you collect your fees up front? Unless you have something in your contract with an insurer that prohibits it, the answer is yes. But that fee better be only the patient liability. I've had some clients say, let's collect the whole amount of our billed charges, and then when we get the insurance payment, we'll refund the amount to the patient. If you have a contract with the insurer, the contract is likely to prohibit that. And then the other thing, if you do this, you have to be very wary of credit balances, which brings us to the next question. Do you have to refund all credit balances? In a lot of states, the short legal answer is yes. I am a fan, this is when we're all bend the rules a little bit, and my WWYW, which is what would you want? I had a client once that said they would only refund credit balances of $500 or more. And I thought, how would you feel if someone said, we owe you $499, but we're hanging on to it? You'd go crazy. I am okay if you have a principle that is we will neither bill a patient nor refund X amount, because it costs too much to generate a bill. $5 and less, either way, we write off. It is not clearly legal to do that. I just think it's unlikely anyone will squeak. Now, if the amount that you're picking there happens to be the amount that people often have as copayments or coinsurance, the person who might squeak would be an insurance company who says, we want you to collect the copay. But otherwise, from a practical level, I think you're in pretty decent shape. From a purely legal standpoint, many state laws require you to refund any credit balance and then also to turn over to the state any amount after a certain amount of time. Can you charge patients who no-show? The answer is it depends. Private payers, you're going to totally have to check your contract. If it's Medicare, this is a surprising answer. The answer for Medicare is yes, as long as you don't do it only for Medicare patients. There's a Medical Learning Matters that deals specifically for this, and it says that the charge is for a missed business opportunity, and so it's okay. For Medicaid, it depends on the state. Most states will say no. Actually, I'll take a question that someone asked me recently too, which is, can you charge a billing, if someone doesn't pay their fee right off the bat, can you charge them, kind of a rebilling fee? And the answer to that isn't crystal clear, but on that same logic that I just alluded to of it being a business expense, the answer might be yes. But it's not, I don't know that I would do it, quite honestly, but there's an argument to be made. Can you stop seeing Medicare and Medicaid patients? Well, if someone wanted to attack it, the best argument to attack it is that you're discriminating against Medicare patients on the basis of age. I think that's a pretty weak argument because you can have young Medicare patients. Many people are over 65. You can be Medicare at any age. And the reason you're doing it isn't age-related, it's payment-related. And so I feel pretty comfortable doing that. You do have to know that if you're a hospital or another provider that has a provider agreement with Medicare, CMS can terminate a relationship with you or if you refuse to accept patients unless you're applying the criteria to all patients. But there's no similar prohibition for clinics, physicians, and other suppliers. Medicaid's going to vary. Many states have limitations on your ability to discriminate against Medicaid patients, and some use a carrot and a stick saying if you exclude Medicaid patients, there's a price like you can't see state employees or the like. So can you waive copayments? There are three kinds of sets of laws. There's a Medicare anti-kickback statute and the civil monetary provision. Actually, I guess there are four because there's Stark, which should be on here, and then state law. All of those come in to play. So the anti-kickback statute makes it a felony if the reason you're waiving the copay is to influence referrals. I saw a note once, don't charge him, he's a good referral source. I think that note all by itself is a kickback problem. So if you're doing it because someone's a good referral source, that's a problem. If you're doing it because the person is upset because they've potentially been injured in a malpractice case, that I think is just fine. The civil monetary penalty is similar to the anti-kickback statute, but it's a payment that you know or should know is likely to influence the beneficiary's selection of a particular provider. An interesting question is, does that have to be prospective? If you waive a copayment from an unhappy patient, Is that influencing their choice of provider? I'd feel pretty comfortable defending a case like that. Many states extend the state anti-kickback statutes that extend the law to all patients, not just federally insured patients. And then there's the Stark question, which if like a hospital is giving a discount to a physician, there is a Stark exception that is spelled out. And I thought I had a slide on that one specifically. I do have that in a moment. All right, can you give free care to employees? Sort of. First of all, there are benefit plans issues that I am not an expert on. We have a couple of lawyers here, Lisa Robinson and Deb Linder, who are way smarter on that than I. Waiving copays to employees can generate potential benefit issues. And also, there's just something to keep in mind. We've had some situations where people have sought care from their employer and then complained that the employer discriminated against them based on the knowledge they learned in those visits. So there's a question as to whether you want to create a financial incentive for the person to come see you or not. But if you give totally free care to employees, I think that's generally going to be okay with this possible benefit plan question. And one of the benefit plans issues is whether you wind up discriminating in some shape, way, or form, because certain people are going to be more likely to use that than others. Now, I don't think you should give free care to employees, because the question is, who does it benefit, really, the employee or your insurance company? Because ultimately, to get your employee a small copayment benefit, you're giving an insurance company a big benefit. So I wouldn't do that. Personal advice, if you feel bad taking copays from your employees, I would do one of two things. I would ask the insurance company if they mind if you waive the copay, or take all the copayments, throw them into a fund, and throw a party, or give it to charity, or do something like that. So can you give free care to doctors? We've already talked a little bit about the anti-kickback analysis. It's important to note that Stark can apply if Stark makes it improper to bill. If you have a financial relationship with a doctor, if the financial relationship doesn't meet one of the law's exceptions. And anytime you provide any of the designated health services, which are listed here, you are implicating Stark. And so if you're a hospital, every financial relationship you have with a doctor, by definition, if that doctor admits people to you, implicates Stark. If you're a clinic and that doctor and the relationship you have, the physician you have a relationship sends patients to you for one of these things, Stark applies. There is a safe harbor under Stark that allows you to give discounts, but it only applies to the organizations that have a medical staff and then meets the criteria on here. And I'm just going to blow through that one really quickly because I'm not as interested in that as some of the other stuff, and I want to leave Steve about 15 or 20 minutes to talk about the new rules. Can you give discounts to the poor? And the answer is yes. The only reason I have this slide is there was a time about 7 or 8 years ago when the American Hospital Association said that it wasn't clear hospitals could give discounts to the poor, and that's why some hospitals didn't. And I never understood that position. The poor aren't covered by the anti-kickback statute, at least if they're uninsured. The uninsured poor aren't covered by the Medicare or Medicaid anti-kickback statute. You can give discounts to them. The potential implications are the effect that might have on your billed charge. It's not an illegal inducement. Do you have to provide charity care? And if so, how much? So it's important to distinguish between may providing charity care and must. Hospitals at this point have to have some sort of charity care, at least if they're a nonprofit. For-profit hospitals don't. Clinics, unless you are a tax-exempt hospital, even if you are a tax-exempt clinic, you don't have to provide charity care, but you may. So the federal tax exemption requirement, there are various activities. You have to engage in charitable activities, which can be relief to the poor or also education and science. Now, PPACA has required studies on how much you are providing charitable assistance if you're a hospital. That only applies to hospitals, not to clinics. So there is some guidance if you're a hospital, how much charity care do you have to provide? Well, there's some guidance in the provider reimbursement manual about what you need to do. You can't write off bad debt and call that charity care. It has to be done on a prospective basis. And you have to kind of determine how you're going to do it. You have to do it ahead of time, and you have to have affirmative documentation backing up your decision that the person was poor. You can't, after the fact, say anyone who didn't pay us was de facto poor. Do you have to put a patient into collections? In a clinic, the answer is going to be no. Hospitals, it's a little more difficult because if you want to claim bad debt on a cost report, you have to take reasonable collection efforts, which doesn't necessarily mean putting patients in collection, but it might. That's a little unclear. For clinics, the only question is whether your fee is real. So I wouldn't like a situation where you say, hey, there's a copay, wink, wink, don't pay it. But you aren't required by law to put patients into collection. And then when do you claim bad debt? And like I said, this is only for hospitals. So here are the basic criteria for claiming bad debt. You basically have to have sound business judgment that there was no likelihood of recovery, and you have to have made efforts to collect it and the like. And you can read that if you're a hospital. So kind of the last area we're going to cover is, can you charge interest on debts? There are a couple of issues to keep in mind here. Federal and state law. Federal law includes the Truth in Lending Act that is complicated. When you get a credit card statement and it has all these words on it and about, kind of all those disclosures, that's part of the Truth in Lending Act. And as soon as you're charging interest, you need to start paying attention. If you're extending credit to patients, you have to make periodic disclosures that look like those credit card statements. You can usually charge some small interest rate in a state without triggering that federal Truth in Lending Act, but it's something you want to be aware of when you start to charge interest. Also, many states have usury laws that can vary from charging 4% as improper to charging 16% as improper. Let's talk about Medicare and Medicaid policy. So Medicare is a really interesting one. A whole bunch of MACs have said you can't charge patients interest. And I had a client get a letter from CMS saying you can't charge patients interest. They cite a federal regulation, and here's the federal regulation. It basically says you can only collect the difference between what Medicare Part B will pay and the approved amount and the total charge. So you can collect the copay and the deductible, and that's it. And so they cite this as authority for you can't charge interest. I think that's a bunch of bunk, and I base this on the Medicare Learning Network matters, which we talked about earlier, about missed appointments. So here's the text. The charge for a missed appointment isn't a charge for the service, but rather a charge for a missed business opportunity, and therefore you can do it. Interest, to me, isn't a charge for the service. The patient has already got the Medicare service. They're not paying more because of the interest. It's a charge for a lost business opportunity. So I think Medicare's analysis on this is just plain wrong. I wrote a long letter to Medicare telling them I thought they were wrong. They said that my analysis was wrong, but they refused to write back and refused to share anymore. And I will note that they never went after the person who they told that they told my client that they had to refund a whole bunch of interest, and we said we weren't going to, and Medicare dropped it, which I think is an interesting little point. So, last slides on interest. Just a couple of examples of states picked at random. In Minnesota, you can charge without a written agreement with the patient up to 6%. If you have a written agreement, you can go up to 8% interest, but if you're going to try to go over 8%, you need a special license to do it. Georgia, by contrast, was below 7%. You don't need a written agreement. It looks like you might need a special license to go above 8%, and the real illustration of this point is it varies a lot state by state. The last slide I've got is something to keep in mind about if you're ever trying to collect from patients. There are weird limits on what you can do. There's a Fair Debt Collection Practices Act, and it's beyond my pay grade. I think it's beyond Steve's pay grade. But you can't. You can only call between 8 a.m. and 9 p.m. If the patient has an attorney, you have to work through the attorney and the like. It's just one of those little landmines you can step on. And so now for something completely different, I'm going to turn it over to Steve, who's going to talk about provider-based billing and also some of the proposed rule.
So this is a little bit of a shift in focus, but we wanted to talk about a few of these things because we often are in the position where we're trying to figure out what's going to happen next. In particular, what's going to happen next with pricing and whether it's going to affect the way we deliver care, the way we structure relationships among healthcare providers. And we get occasionally something from the government that gives us a little glimpse into the future, perhaps a little look into the crystal ball and lets us sort of speculate what's going to be happening in the future. So a couple of those have happened in the summer. One of them is the proposed regulation for the outpatient prospective payment system. That's hospital outpatient reimbursement. There will, of course, also be an inpatient prospective payment update, and there will be a physician fee schedule update, and those come out at various times during the year. There are a few things that are interesting in the outpatient prospective payment proposed rule, and this isn't a final document. The other thing that comes out on an annual basis is the MedPAC report to Congress, where MedPAC says, we have been looking at the healthcare system and the way Medicare pays, and we've got a couple of ideas, Congress. Actually, it's usually more than a couple of ideas and hundreds of pages. Just as the outpatient prospective payment system update is hundreds of pages of almost unreadable text. But this stuff comes out, and it gives us a hint at where the government is going. And the government is doing this on a couple of levels. Number one, it has regulatory power, and it will have increasing regulatory power over the next few years under PPACA, because PPACA has established or will establish a number of sort of new agencies within the government bureaucracy that are designed to innovate in the area of Medicare payment. So there are regulatory shifts in what we get paid. And then to the extent that a statute hasn't already authorized a particular idea, the government can always resort to Congress, as MedPAC does when it makes its report to Congress, and say, here's what we want to do to, in a larger way, kind of overhaul some of the payment provisions in the law. So if we look first at just the outpatient payment update, we find a few things, none of them particularly earth-shaking. I would characterize them in a couple of ways. Number one, in almost every instance, they are trying to achieve some little level of savings, mostly savings at the margins, and they try to suggest that the savings are not very big. And number two, in many of these situations, what they're trying to do is expand a principle that they're particularly interested in, and we might expect them to continue to expand this principled way of reducing overall costs in the future. So the payment revisions design, first of all, what the payment increases are for, among other things, regular acute care hospitals and ASCs. There are also schedule updates for critical access hospitals and some of the other outpatient entities. And you can, if you want to get the big report, it's, as I say, 300 pages. If you have a question, that's a particular question about something like that, we can give you an answer. They calculated a hospital update for the outpatient system at 1.8%. The way they get to that is to say there's a 2.5% market basket cost increase over the year. They're reducing that by 0.4% for a multi-factor productivity adjustment, and by an additional 0.3% for a PPACA reduction. So they've basically said inflation for this purpose was 2.5, we're going to give you 1.8. And so they're squeezing when they calculate the payment revision. If you read the impact statement that the government put out, they talk about the enormous additional amount of money that this entails and that it's more than last year. Of course it is, unless you adjust for inflation, in which case it's not so great. The ASC update is calculated in a similar way. It's 1.4% as the sort of basic CPI number that they start with, minus a 0.5% productivity adjustment to get to 0.9%. Interesting here, the hospital outpatient department is doing better than the ASC, and this is something that we'll come back to a little bit later. Secondary, sort of, and this is one of those principled ideas that they have, they've included a number of bundling proposals. And you may remember when they first put together the hospital outpatient prospective payment system, they had an elaborate mechanism for defining outpatient encounters, and they tried to say every thing that was attached to the outpatient encounter, including various kinds of subsequent visits, would all be paid for with the one payment for that encounter. And they floated that proposal. This must have been 15 years ago. And people went, oh, my God, we have no idea how to do that. It'll be a disaster because we don't really have only one person providing this kind of service. So they threw that out the window, and they put out outpatient prospective payment that wasn't very prospective. It defines services, establishes APCs for the services, and, really you'd have to say is very much like just a fee schedule, defining the fees. Well, deep in their minds, they really like this idea of bundling, and they want to say, no, if you come to the hospital and you get a service, we don't want the hospital to add lots of charges for things that we think are elements of the service. So the outpatient prospective payment update includes a number of bundling proposals. They are saying if you have a diagnostic test in the hospital or a surgical procedure, drugs, biologicals, pharmaceuticals, and medical equipment can't be separately paid for. That's not an earth-shaking idea. It's the kind of bundling that's pretty natural. And so I think we can expect to see that kind of change over time continue. Similarly, they've said if you have a laboratory test the same day as another outpatient procedure that's ordered by the same practitioner, that's going to be bundled. So if you have an outpatient procedure, the hospital isn't going to be able to bill for a test on the same day. There are a few other things that are in the bundling proposal list. I don't want to go over them in great detail. Again, this will be interesting to some folks that are particularly right inside the billing organizations of hospitals, and I assume they're studying them pretty heavily. They did something else that I would put in this category of sort of principled changes, where they said, we have outpatient visit codes, which are APCs that correspond to the CPT visit levels that we have out in for the physician services that often correspond with an outpatient visit, and so we've got level 1 through level 5 in an outpatient clinic, and level 1 through level 5 in the emergency room. And we've decided that we don't love having 5 levels of codes. We think that results in upcoding or gives an incentive for upcoding. And so what they're proposing is that they would reduce upcoding by just having one emergency department code and one clinic code.
Makes it harder to upcode.
It makes it harder to upcode. And what it really means is that if you've got a high-level service that might have more intensive facility participation, you might get underpaid for it on the facility side. It also means that if you have a very low-level service, a what used to be a level 1, you're going to get paid too much. So it's a choice that simplifies the issue, and it if anything is sort of consistent with this idea of bundling. We're going to have a simple charge. If you go to the emergency department, you get a physician charge that still varies on the basis of a severity level, but you're going to have an emergency department code that's just the simple visit code. So that's an interesting feature, and I'm going to come back to this in a little bit because we're going to talk about something that is, if anything, a little bit scarier, and that is the MedPAC view of outpatient charges in general. Final thing that I think of as sort of an area of interest by the government in putting together this outpatient proposal is quality reporting. And I think everybody knows that we're on the trail to additional quality reporting, quality payment. What they simply do here is take out a couple of quality reporting measures, add a few more quality reporting measures. I think people are aware that in 2016, hospitals will get paid 2 percentage points less if they don't meet the quality reporting requirements for 2014. So what you do now to do quality reporting may have a big impact on how you get paid sometime in the future.
Steve, before you do the really interesting MedPAC stuff, I'm just going to chime in and say, remember, we've got a bunch of questions here. As soon as Steve talks about the MedPAC stuff, we will answer the questions. You can always type a question in the bottom right corner, and we will try to answer those at the end here. But now Steve's going to it's going to kind of try to predict the future a little bit.
So,
and actually, I'm going to interject one thing. Which one of the questions is what Steve just talked about was only does that only apply to hospitals or does it apply to clinics? And most of what we talked about here is hospitals. What we're about to talk about is clinics are going to care about a lot.
Okay. So MedPAC every year writes a letter to Congress. Again, it's a 300-page letter to Congress. Dear Congress, here are some of our good ideas. In 2012, they said, we don't like the fact that there are Medicare payment differences between a clinic and an outpatient facility. And we've noticed that a lot of clinics have affiliated with hospitals one way or another to create a new kind of organization that's the hospital or provider-based clinic. And we don't love the hospital or provider-based clinic if it's providing the same service, but it is getting paid more. It sounds to us like a way to increase the price. We've also noticed that lots of specialty types, for example, cardiologists, have gone into the hospitals, become hospital employed. When they became hospital employed, they were established in a hospital-based clinic, and the additional payment that comes from the facility side helps to support the physician side. Really another just concrete example of where this difference seems to have made a difference to them. So they have proposed in 2012 and again in 2013 their second major proposal that we get rid of the difference. So for all those folks who have created a provider-based department that functions primarily as a clinic, they would say, well, you should get paid what any freestanding clinic gets paid under the physician fee schedule and not get paid the outpatient APC for the facility service plus the reduced value physician payment under the physician fee schedule. And if you look at what they wrote, and I like the executive summary. The executive summary is shorter. But they say, in general, the Commission maintains that Medicare should base payment rates on the resources needed to treat patients in the most efficient setting, adjusting for differences in patient severity to the extent that severity differences affect costs. So what they're saying is we should look for places where the service is provided in one category of setting like the outpatient department and another one like a physician clinic, and if they're doing the same thing, we should pay the lower amount. And so they are actively working on this. It probably requires congressional action. That's not necessarily easy to get, but if people are looking to the future and they're saying, I'm going to structure a business that I expect to be going forward and being successful over the next 10 years, it is wise to try to structure the business in a way that can be financially successful under a lower payment mechanism. That's number one. Number two, if you're putting together that kind of arrangement with multiple parties, and it depends on a contract between the parties, really useful to have the contract provide specifically that if provider-based billing goes away or a differential goes away and requires us to use a lower level payment system, that the parties will do something like reconfigure the organization. Fairly high level chance, I'm guessing, that this is going to happen. The question is when rather than if, in my mind. And I think it's very possible it'll happen in the next couple of years. The government is more interested in this than they have been in the past. And one good reason for it is that they have cut deals with many of the other people that are paid by the healthcare system that as part of PPACA that prevent those people from getting hurt. And so shifting care, shifting payment from hospital-based setting to physician-based setting is available for them as a significant way to save money. They estimate that there's, something on the order of 1.5 billion, I believe I read, that might be findable by making this change. That's big enough potatoes for them to be interested in. Let's answer some questions.
Yeah, and as I start to answer the questions, there's some of this stuff is really hard. As Steve has slogged through some of these new rules, he said, my God, these are too hard for me to understand. And Steve is the smartest person I know. I know reading the new two-state rule that we're going to talk about next week, I read it and thought, oh my God, this is humbling. I can't figure this stuff out. So I think one of the scary things is we're in for a run here where things are going to be really hard. So the first one that's going to be really hard, here's one. It's a great comment from someone saying, well, what about Section 111, the Medicare secondary payer reporting? This was a section that when I looked at was, once again, I was humbled. It took me a long time to understand it. And it's a really good point. There is a law out there that a lot of people don't know about that can require reporting when you give when you make a payment on a malpractice claim to a Medicare person and waiving a copayment for someone who's asserting that they have been harmed might trigger that provision. There are a bunch of situations in which it doesn't apply. If memory serves, I think one of them is if you're self-insured and the like. But the person who pointed this out makes an excellent point, and so I just tossed that one out. It's a factor that I did not mention that's out there. Steve, I'm going to see if you know something about this one. I heard a recent IRS rule or communique about the prices that a provider can charge non-insured patients or self-pay patients. It stated we have to charge what Medicare pays or an average of the current charger payers. Is this true, and is it in effect now? One thing, just right off the bat, it's important to understand the IRS has no impact on anyone who is not a tax-exempt entity. So if to the extent that this exists, and I don't know that it would only apply to tax-exempt organizations. This one is not ringing a bell with me. Steve, are you better on that one than I?
No, I don't. I don't think this is enforced, but I don't know. So I wouldn't give you a definitive answer, but I don't believe so.
Okay, Steve, if you want to take a shot at this one, all right. So what about EMTALA requirements? If we've got a patient who hasn't paid, and we're a provider-based entity, we're a hospital, and we've got a provider-based clinic, can we say to the patient, you haven't paid us, we're not going to treat you?
So. If we're a hospital emergency department and someone presents at the emergency department and they say I've got an emergency, we're going to have to give them a screening exam and the care that's necessary to stabilize the patient. We're not going to be able to take into account who the payer is, whether it's a third-party payer or the patient. So that is an excellent point. EMTALA makes it very difficult to deal with and to do upfront billing or to chase the patient or to threaten the patient for that they'll be kicked out if they don't pay.
But that's not applying in the clinic setting, only
that's for the
hospital only.
Hospital emergency departments.
Okay, next question. So Blue Cross Blue Shield is saying we can't bill for services that are not medically necessary. We had a patient sign a waiver, but the insurance company is saying that because we didn't specify the type of the service or charge, we can't charge the patient.
Here's a related question, David.
Yeah.
So let's put these two together.
Sure.
This one says, do you have to take a contractual reduction on a charge which is non-covered under the patient's insurance plan, or can you collect 100% if it's non-covered? So several categories of issue here. Number one, is it covered? Number two, is it covered in certain circumstances, not covered in others, and you can get the patient to say, I'm waiving the insurance and paying myself.
Yeah. So let's talk about ABNs for a second, for advanced beneficiary notices. So in the private pay context, you're going to have to look at your contract and see what it requires. Generally, it's not going to be enough to say to the patient, you're responsible for anything your insurance didn't pay. Most insurance contracts now are going to require some sort of specific notice to the patient that this particular thing might not be covered. And so a lot of it depends on what your waiver looks like. And when they're talking about a generic, what they mean is if every person who comes in signs a form that says you might be responsible for for uncovered services, a lot of insurers are going to say our contracts and our policies say you have to be more specific. And so if you've got that in your contract, then the answer is no, you can't charge the patient. But, and this is where I feel like a wimp, but I have to say, we got to know what your contract says.
I think that's right. Under Medicare, there's a distinction between services that are not covered at all or services that are not covered in a certain circumstance because they are not medically necessary.
Right.
And I believe that the ABN is applicable to the not medically necessary services and not applicable in situations where they are statutorily eliminated from coverage.
Yeah.
So the ABN is ineffective in that situation and only effective when it's a not medically necessary service. If a service is non-covered, clearly non-covered, then neither the contract nor the Medicare law should have an impact on whether we can collect the fee.
Yeah, so cosmetic, certain cosmetic procedures, for example, can be affirmatively uncovered. Can you send a patient a bill to collection if they don't make the expected minimum payment? For example, the clinic policy says that you owe $75 or 20% of the remaining balance, and the patient want to make $10 monthly payments. If they don't make that minimum payment, can they be sent to collection? And I would say I am not a collections expert, but I would say the general answer to that's going to be yeah, you can. The only thing would be if there's some state collection law. And you do have to be wary. I mean, a lot of attorney general one of the things that's happening right now is we're seeing attorney general investigations in things where the attorney general thinks that the thing might be unfair but not necessarily illegal. And so if they think that this person is uninsured and being treated unfairly, might you get attention for this? Yeah, but that doesn't mean you've done anything wrong necessarily. Can you put people in collection? Yes, you can.
Here's one. What can be done about takebacks from insurance after service has been completed and a prior authorization was obtained? And, this is another one that, unfortunately, is a matter of the contract between you and the insurance company. Insurance frequently says we're going to self-adjust. It's very difficult to deal with them when they self-adjust. Sometimes either the contract or the combination of the contract and their manuals gives them wide ability to self-adjust. If they're doing it unfairly, there may be an appeal mechanism. You've got to sort of look through the contract and maybe talk to somebody about it. A prior authorization is a classic situation where it's difficult for them to figure out if it was obtained properly or not. Ultimately, if the service is provided, they ought to pay you the money, and a technicality shouldn't get them out of it.
So the next one is more of a comment, and it believes that the question about the prior question was referring to proposed 501R rules for tax-exempt hospitals, and that's believable to me. And it highlights there's always a danger of the difference between proposed rules and final rules. And proposed rules are something you pay attention to and comment on. They're not the law yet. Can we write off deductibles and coinsurance amounts for a specific group of people, like nuns? Would it be charitable or bad debt? If you're doing it ahead of time, then it's definitely charitable, and if you have to meet kind of the criteria, as long as there is a charitable reason for it. Actually, Medicare has a specific nun provision in the manuals, and it's been a while since I've read it, but I think that they specifically, I believe, said you could write off things for religious orders. I'm looking to Steve to see if my memory on this is right.
There was a special provision. I'm not exactly sure I can quote it chapter and verse.
We'll have none of that here. Okay, so I think we've run through the questions and the bad puns. So just reminder, next Thursday, Katie Ilton and I've gone to her maiden name, are going to try talking about the new short stay rule, and we'll try to explore what that means from a practical level, how it changes from the current thing. So that's special time. It's at 11 a.m. Central, noon Eastern, 9 Pacific. I think there's some folks on here from Alaska. 8 a.m. Alaska and 7 a.m. in Hawaii. And then on the 11th, we'll have the special HIPAA training webinar. Remember that if you've liked this so much, you can send it to your friends via SlideShare and make them suffer too. The SlideShare link will be coming out shortly, and I think that pretty much is it. You'll get the evaluation, and one of the things we got a ton of really good suggestions for future topics. In fact, so many that they're going to keep us busy for a while. But we like more suggestions on topics. Those are useful. And then also just feedback on parts of this that are useful or not. We do know sometimes the sound breaks out over the lunch hour. And I guess the only thing I'll say about that is remember you can always dial in. Unfortunately, we don't control the internet. Steve's been telling me to wrap it up, and he's right, so I'm wrapping it up. We're done. Have a great day.